Okay, good afternoon, everybody. Welcome to the IMS webinar on female hormones and COVID and how relevant are they. We have two excellent speakers. Please, if you want to ask any questions, which we'll do towards the end of the session, please can you put those into the Q&A discussion box, and then we'll go through them at the end of the two presentations. So we're fortunate today to have two excellent speakers who are going to cover different aspects of female hormones and COVID. I think again, the COVID pandemic has highlighted differences between men and women in response to virus infection. This is something we've known about for some time, but has been exacerbated and if you like, accentuated by COVID. The lower severity and mortality of COVID-19 in women has prompted many studies examining immune responses, biomarkers, and indeed the role of sex hormones. More recent studies have also shown that the long-term effects of COVID are more common in women. So-called long COVID is at least twice as common in women as in men, with a median age of about 45. So we know that there is a significant burden of disease, and that disease is gendered. It appears to be different in men versus women, and we'll get to hear a bit about that this afternoon. The first speaker may be very familiar to you. Louise Newson is a GP and a menopause specialist. She's created the menopausedoctor.co.uk and the Menopause App Balance. She's founder of the Menopause Charity and a director of the not-for-profit company Newson Health Research and Education. Louise has contributed to many menopause-related articles in the media, and she also hosts a weekly podcast for women. She's going to kick off the session with her presentation on the protective role of Oestradiol in the COVID-19 pandemic. So I'll hand over to Louise. Thank you. And just to mention that the webinar is supported by an unrestricted grant, but I'm handing over now to Louise.
Thanks very much, Lawrence. Just share my screen. So hopefully you can see that all right. So I'm, as Lawrence said, I'm a GP and I'm a menopause specialist, and all I do at the moment is live, breathe and think about the menopause, but I've also got an immunology degree as well. So I just wanted to talk about my thoughts, some about the pathology and immunology, and also about the evidence that we have. So just to start with my declarations of interest, I don't have any financial disclosures. I do no paid work with any pharmaceutical companies. As Lawrence said, I do run a menopause clinic, and I think it's probably the biggest menopause clinic in the world, actually. We see over 1,500 women a month in my clinic, and I have 41 doctors working with me. It's a private clinic because none of us can get jobs in our National Health Service because there's no provision for menopause care near where I live. I also run a not-for-profit company. I've founded a free app, and I just recently founded the Menopause Charity. I do have one declaration though, in that I take HRT, and I actually wouldn't be able to work without it. My brain completely went when I was perimenopausal. So obviously we all know that the menopause affects all women. The average age is 51, and 1 in 100 women, as you know, have POI, premature ovarian insufficiency. As we're living longer as women, we're more likely to be menopausal for longer. And in fact, around 1/3 of our lives are postmenopausal. And for me as a physician, so just to get the record straight, I'm not a gynecologist, I'm a physician and a GP, but 1/3 of our lives are postmenopausal. So that means that we have low estradiol levels for a significant chunk of our time. And actually for young women who have POI, it's even longer. And so not only does this cause symptoms, but there are numerous health risks associated with the menopause. So a lot of the work I'm doing is trying to change the narrative of the menopause as something that causes some hot flushes in middle-aged women to actually a female hormone deficiency with actually quite significant health risks. We all know the influence of estrogen all over our bodies because we have estradiol receptors all over our bodies on every single cell. So we've got really good menopause guidelines. We've obviously got the nice ones in the UK and the International Menopause Society guidance that came out in 2016, which are very clear with really good information and guidance. And they're very clear about giving individualised care to women. And also for the majority of women, the guidelines are very clear that the benefits of HRT outweigh any risks, and women can take it forever, usually. And that's because you're simply replacing the missing hormones. But we also know only the minority of women globally take HRT, which really obviously needs to address, because not only does HRT improve symptoms, it actually improves benefits as well. So it will improve symptoms, which is great. As a clinician, we can make people feel better. But actually, more importantly for me as a physician, it actually reduces the risk of really important diseases such as osteoporosis, diabetes, cardiovascular disease, osteoarthritis, type 2 diabetes, dementia, clinical depression, and mortality. Actually, follow-up from WHI has shown reduction of mortality from all causes. But the big question here is HRT actually able to reduce not just severity of COVID, but mortality from COVID? We're here with a pandemic. COVID is going to stay, so we need to really think about this. So we know that women and men have different immune systems. Obviously, we have 2 XX chromosomes and men only have 1. So there is a lot of narrative. Is it about the regulatory genes that are encoded in the X chromosomes? And actually, that will be relevant, but it doesn't explain the big differences across age groups as well. So there are other reasons involved, and I'm sure a lot of it is going to be estrogen. For these slides, I've given the US estrogen and estradiol rather than having the O, just for clarification. So we know that our levels of estradiol and reduce during the perimenopause, and they're low during the menopause and after the menopause. So they're consistently low unless we take HRT, of course. So looking at COVID, we know it's a severe acute respiratory syndrome coronavirus. And it's a novel coronavirus, and we know that one of the biggest causes of death really is this severe acute respiratory syndrome. It's led, I mean, the numbers are increasing all the time, aren't they? But more than 163 million people have been infected worldwide, and over 3 million deaths. We've known from very early on, actually, that men are more likely to die, and women have a lower incidence of pneumonia, sepsis, and multi-organ failure. So the gender differences have been always apparent, and men are at a higher risk of more severe disease as well. Men are far more likely to go to ITU, and as well as being more likely to die. And looking across all ages, men are nearly twice as more likely to die from women. And right from the start, when COVID appeared, I kept thinking, I wonder if there's a difference. Why is there a difference just because of estradiol? And it's just been in my mind for a long time. We know that low estradiol levels are associated with more of a severe infection, and a study from Wuhan came out quite early on last year, showing that there was an association of worsening lung disease and worsening infection severity in women who had low estradiol levels. There's also a study looking at male mice with SARS coronavirus who had a worse prognosis than females, and also when they removed their ovaries, they had a worse prognosis as well, or gave estrogen receptor blocking drugs to these mice. In addition, especially in their lungs, they had an increased number of inflammatory monocyte macrophages. And these cells, these IMM cells, are really key, actually, I think, to a lot of what's going wrong. So this is quite a busy slide, but it's just to highlight, I said at the beginning that we have estradiol receptors on every cell in our body, and that's no different for our immune cells. So whether it's our B cells, our neutrophils, our dendritic cells, our T cells, they're really, really important. And when estradiol stimulates these receptors, it has really beneficial effects to our immune system, and it affects the production of different cytokines as well. So this picture, I think, is really pivotal when we think about why our immune system as women is so much better than men's. So we know that women have a better innate and adaptive immune responses than men. That's been known for decades. We also know that men are more likely to succumb and have sepsis compared to women before the menopause, so women who have estradiol in their system. I've already said we have estradiol receptors on every single immune cell, and the stimulation of these immune cells by estradiol can improve the differentiation of these blood cells, but also the genetic reprogramming, the functioning, and the lifespan of immune cells. I've already said it affects the cytokines, and if you're thinking about, or as we're thinking about COVID, especially important interleukin-6, Tumor factor, and interferon as well. We also know, which I think is really important with COVID, that estrogen can damp down and attenuate the cytokine storm. And as you all know, the cytokine storm is often what leads people to go to intensive care and actually die from COVID. So this is really important. We also know, obviously, that autoimmune diseases are more common in women than men, and this is likely to be associated with estradiol. This protective effect of our immunity that I've mentioned is diminished in postmenopausal women who clearly do not have estradiol or much estradiol in their bodies. We also know that there's a dose-dependent effect of all these beneficial effects of estradiol. So if estradiol levels are low, then actually it causes a pro-inflammatory response. And menopausal women with low or no estradiol levels have an increased leukocyte adhesion and IL-8 production, and also the monocyte chemoattractant protein 1 expression. And the HRT, or the estradiol HRT, can reverse this inflammation. So a low-grade pro-inflammatory effect is actually quite dangerous for the body. So if we look at the IMMs, the inflammatory monocyte macrophages that I mentioned before, actually they're the predominant source of the pro-inflammatory cytokines during the lethal SARS, and they can produce lung cytokines and lead to vascular leakage and impair the T-cell response. And so these cells are really bad news, actually, and it's bad when they're not working well. So the estradiol suppresses the way that they work and the recruitment of them. So they down-regulate the MCP1 expression during the inflammation, and they also inhibit the toll-like receptor 4, which is mediated by nuclear factor kappa beta, which actually regulates the innate immune system. So this whole balance, I mean, how our bodies work is just incredible, but this balance with the not having enough estradiol compared to having a good level really shifts and changes the way that our immune system works and the way that COVID responds actually to the immune system, which is pretty important. We've known that estradiol can be very important in other viral infections, and we know that infections such as CMV, HIV, influenza, but also in Ebola as well, is a lot more severe in men compared to women. And again, it's related to the way the innate and adaptive responses in women occur. But it's not just, estradiol is amazing, obviously. It's not just the way it affects our immune system. We look at ACE activity, and we know how crucial that is in COVID. So the regulation and expression of ACE2 is really key for the virus to enter the cell and cause damage. So we know that estradiol down-regulates the angiotensin II receptor type 1 signaling pathway and actually inhibits ACE activity. It leads to a positive effect of expression of ACE2 protein and also increases the activity of it as well. And we know that when this happens, these effects are anti-fibrotic, antioxidant, and lead to vascular dilatation, which is very protective when thinking about COVID. There's also TMPRSS2, which some of you hopefully have heard of, which is transmembrane protease serine 2. And this is very important for the virus to actually enter our host cells. And what it does is it primes the spike protein, and it's the only critical protease for the pathogenesis and viral spread of SARS-CoV-2. So it's very important thinking about how estradiol has an effect, not just on ACE2, but on this key protease. And we know that 17-beta estradiol increases the expression level and activity of ACE2, but also it alters the TMPRSS2 expression, which when it's bound to the estrogen receptors, the ER alpha receptors. And so this then inhibits the virus actually entering the host cells, which is really important when thinking about immunity and response to the COVID infection. And so also, not just leaving it at that, we know that endothelial dysfunction is really key in COVID infections, and we know we've heard so much about the venous thromboembolic risk with COVID-19, and certainly endothelial dysfunction contributes to this. We know that endothelial cells possess both ACE2 receptors and TMPRSS2 receptors, and estrogen plays a very protective role in endothelial function. We've known that for many years, and we know that women who start HRT within 10 years of their menopause have a lower risk of cardiovascular disease, and it's very anti-inflammatory on endothelial cells. We know that estradiol can activate nitric oxide and prostacyclin production. It also can reduce oxidative stress and platelet activation. Also, these pro-inflammatory cytokines. There's a promotion of pulmonary microthrombus and increased expression of adhesion molecules during endothelial activation and procoagulant effects, which can be reversed by estradiol. So we know that endothelial damage is more likely in patients with hypertension and diabetes. And estradiol can stimulate the gene and protein expression on endothelial cells, so actually reduce this response, which again is another way that estradiol can be very beneficial. So not just on the way it affects our immune system, not just the way it affects the virus to enter the host cells, but also to reduce this procoagulable state, if you like, which is affecting a lot of people, again causing their demise by microemboli, especially in their lungs. So we know what's the evidence for this? Well, we know obviously that there's less deaths in women who are young, pregnant, but also taking hormones. We've known from in the UK in the ISAREC data, which is the International Severe Acute Respiratory Infection Consortium, their data is known even from quite early on, actually from sort of May last year, that women taking HRT were less likely to die and had a statistically significantly lower risk of death. Talking to Hugh Montgomery, who's a consultant of one of the main intensive care units in London, he's still not actually seen a woman who's taken HRT go to his intensive care unit. Women taking HRT, we know also, don't we, that they're less likely to have cardiovascular disease, diabetes and obesity, and those three are risk factors for severity from COVID. Talking to some of the researchers when they did estradiol levels of some of their samples of people who've been in intensive care with COVID, they found that the levels of estradiol were below detection, which I think is actually really significant. So what about the evidence for actual estradiol in HRT for women with COVID infection? Well, there was a study that came out, a cohort study came out last year, nearly 70,000 patients who had documented COVID-19 from 17 countries. Now, this was a retrospective analysis from TriNetX real-world database, and this is really good database, a network of more than 300 million patients. And the data was collected from electronic health records, and it was a laboratory-confirmed COVID-19 diagnosis in these patients. They found that the death rates for women compared to men was as predicted as we know from other studies. And if you look after for the women in red, over the age of 50, 55, it suddenly goes up. And I don't think it's a coincidence that that's around the time of the menopause. So looking at their results, they were found that there was a benefit in the estradiol hormone user group. Obviously, the numbers were small because I've already said at the beginning, not many people take HRT. But it was very interesting that the fatality risk for women over 50 who were taking HRT containing estradiol was reduced more than 50% compared to non-users. The odds ratio was 0.33. And the risk reduction for fatality compared to users to non-users was statistically significant, and this graph just shows you the survival probability to those people who were taking estradiol where it hadn't really reduced much to those who were not taking HRT. This was another study that came out more recently from the UK, from an Oxford database, and this was looking at a database of 465 GP practices of more than 3.7 million people. And this was looking at those, not all with confirmed COVID, so confirmed or probable based on typical symptoms. And they looked at all-cause mortality as their primary outcome. A lot of people a lot of women in this study, over 1.8 million, just over 5,000 had COVID, and there were 235 women with HRT prescriptions, and also 171 women with the combined oral contraceptive pill prescriptions, and 664 women died. So looking at their results, those women who had taken HRT, they matched them with women who were not taking HRT, and they found there was a significantly lower likelihood of all-cause mortality, and the adjusted odds ratio was 0.22, so even more significant, actually more relevant probably than the other study, which the odds ratio was slightly higher. A real drawback and a shame about this study is the dose and type and also the duration of a person taking HRT wasn't examined. And there's no doubt that having transdermal 17-beta estradiol is very different metabolically to having oral estrogen in oral medication or oral HRT. The metabolic processes will be very different. And also, I've already explained there's a dose-dependent effect. Over in the UK, a lot of women, especially in primary care, are still using oral estrogen. So I think this actual result, if they only looked at transdermal 17-beta estradiol, would be even better. Interestingly, looking at the combined oral contraceptive pill use, they had no reported deaths, so they couldn't do any more data. But I think this is actually quite significant as well. So just some other supporting evidence. This is an in vitro study that was done, and it showed that estradiol reduced SARS in vitro, but it also, I think this is a really interesting study, that it reduced the TMPRSS2 gene expression after infection with the coronavirus. And the estradiol, we know, affects the expression of the majority of human genes, encoding the targets for the COVID infection. So I think hopefully this has shown that there's so much out there, but it's just not being talked about, it's not being thought about. And I think part of the problem is that people don't understand the immunology behind estradiol, they don't understand the physiology and the importance actually of estradiol, because for the last 20 or so years, we've all been told how dangerous it is and how much it can cause cancer. And nobody's thought about the benefits. And certainly some of the researchers that I've been trying to engage with in the UK have said, well, Louise, if you give women estradiol to protect them from COVID, you're going to just give them breast cancer, aren't you? Which is incredibly frustrating. There was a study in America that was going to start giving estradiol transdermally to men and women, actually, who presented to hospital with COVID to see if that would reduce their severity and ITU admission. But there wasn't enough interest in the study. I think partly in America, they were all scared about HRT. But it's certainly something that really needs to be looked at more. Just finally, really leading on to Jackie's talk, thinking about menopause and long COVID. We all know the symptoms of the perimenopause and menopause are very similar to symptoms of long COVID, especially reduced stamina, brain fog, memory problems, fatigue, even shortness of breath can be a symptom related to low estradiol levels. We recently did a survey, not a very big one, just of 460 women, and we found that half of them had reported their periods had stopped or changed since their COVID infection. The majority had said their periods had not returned to how they were before their COVID infection. 62% said that their symptoms of long COVID were actually worse before their periods occurred. And as we know, that's when estradiol levels are at their lowest. The majority, actually, the women themselves, thought that some of their long COVID symptoms could be due to their perimenopause or menopause. But hardly any of them, the vast minority, had ever been asked by a healthcare professional about whether or not they could actually be perimenopausal or menopausal. And I'm sure some of these women might have both long COVID and be perimenopausal or menopausal, or some of them might not even have long COVID. So we need to be really careful that as clinicians, if we're seeing women with long COVID, we need to be asking them about their periods. So finally, where to go from here? I hope I've highlighted to you the importance of estradiol, and I've sort of glimmered at how frustrated I am, because I've engaged with lots and lots of research groups over here, and everyone says it's very interesting, but they're not taking it any further. And I have said to many people, if we took out the word estradiol and said, we have a new drug that can reduce mortality by nearly 80% if people take it. And not only that, it will reduce risk of heart disease, diabetes, osteoporosis, dementia, and it's dirt cheap and safe. And it doesn't increase risk of clot. Would you like some? They'd be all over it. But it's because it's got a female hormone associated with it, because it's estradiol, people don't seem interested. So this is how I spend a lot of my time looking, and I'd be very pleased if someone could disprove me, and then I could be quiet about it and carry on with my day job running a clinic. So obviously more research is really, really needed in this area. So thanks very much.
Great, thanks very much, Louise. That was really thorough and demonstrates actually the breadth of impact actually of estradiol. I guess teasing it apart mechanistically is always going to be challenging, and we might want to come back to some aspects of that in the questions and answers. So hand over now to Jackie Maybin. Jackie is a senior clinical research fellow at the MRC Centre for Reproductive Health at the University of Edinburgh, and she holds an honorary NHS consultant contract in gynecology at the Royal Infirmary of Edinburgh. Jackie also holds a Wellcome Trust clinical career development fellowship, and her research aims to develop better preventative and therapeutic strategies for abnormal uterine bleeding. She's specifically looking at the role of hypoxia in menstrual physiology and pathology, with the aim of developing more effective and acceptable treatments for heavy menstrual bleeding. And she's going to talk to us about the long COVID and the menstrual cycle. So over to you, Jackie.
Thank you very much for that introduction. I hope you can all see my screen. I'm absolutely delighted to have been asked to speak at this seminar today. Thank you very much to the hosts. I wanted to go through some information about long COVID and the menstrual cycle. And I think I'm going to declare from the outset that perhaps unashamedly, I'm going to probably pose more questions than give you answers, because I think we're really in our infancy about what we understand about COVID and its relation to the menstrual cycle, and in particular in relation to long COVID. Let's see if I can move forward. So I want to start today by giving you a few definitions. I think unless you can define what you're researching or looking into, it's very difficult to make progress. So I want to run through some definitions of menstruation, typical menstruation and atypical, and then a definition of what long COVID is. And I think that is still a work in progress. But I want to spend most of the time discussing how long COVID may influence the menstrual cycle and how menstrual cycle may influence long COVID. So firstly, I want to talk about menstruation and how we define that. And this has been an area of contention over a number of years. I think in different places, in different countries, different terms mean different things. So there's been a lot of work recently to try and standardize it. But firstly, well, what is menstruation? I'm sure this audience is very familiar with the menstrual cycle, but you know that the follicles in the proliferative phase release estradiol, and that has an impact on the endometrium to increase proliferation. And then following ovulation, the corpus luteum produces huge amount of progesterone, and that really optimizes the endometrium for implantation. But the key event, I guess, in terms of menstruation is the decrease in progesterone that occurs in the late secretory phase of the cycle. And it's this sharp decline in progesterone that really causes a huge local inflammatory response within the endometrium. And if you think about what Louise was telling us about the importance of the immune system in COVID, there is a huge influx of inflammatory cells into the endometrium at the time of menstruation. And this really causes, this is a picture of a hysteroscopic image of inside the uterus. And at the time of menstruation, it really has all the classic hallmarks of inflammation. It's red, it's raw, it very much looks like a wound. And we and others have shown that also following progesterone withdrawal, the specialized spiral arterioles within the endometrium undergo huge vasoconstriction and really give a very intense but transient hypoxia within the local tissue environment. We've shown that this is really one of the key factors for driving the repair process, which allows the endometrium to completely repair without scarring, without loss of function. And this happens on a cyclical basis. And this huge inflammatory response and its resolution are really key events within menstruation. So what's typical? What is a typical period? Well, the International Federation of Global Experts sat down and looked at all of the evidence and research to date from across the globe and have come up with 4 parameters that menstruation should clinically and scientifically be assessed by. So the duration of bleeding is the number of days that a woman would bleed for, and looking at averages, that is 4.5 to 8 days. So there's a bit of variation in what would be considered typical. The frequency of menstruation is clearly the length of the cycle, and that can be anything between 24 and 38 days. So again, there's a good variation of what's actually considered typical. The regularity of menstruation is how much that frequency time frame changes within a year. And if there's less than 9 days variation, that would be considered normal. So again, there's quite a lot of variation even within the same woman. The volume of menstruation is objectively defined as a blood loss, solely blood, of 5 to 80 mils per cycle, which is, I guess, very useful for research purposes, but much less useful clinically. So when things are not typical, what we usually see in clinic and what I see in my menstrual disorders clinics is people coming in with prolonged menstrual bleeding, so bleeding lasting greater than 8 days. Very few people complain if it's too short. It can be too frequent or too infrequent, and this can cause real disruption for women. And regularity is important for women to be able to manage their menstruation. And if there's lots of variation with their cycle length, then that can cause real issues. And then this issue of volume, what is too heavy? I think I've already said that the objective definition is greater than 80 mils per cycle. And we know that if women are repeatedly losing more than 80 mils per cycle, then they become profoundly anemic and may require blood transfusion. But what's actually much more useful clinically is the impact it has on a woman's life, and that varies from person to person. The woman on the left of your screen working from home may be able to manage 70 mils per cycle without too much trouble, but for the woman in the middle and to the right of the screen, probably 10 mils is too much. So excessive blood loss really has to be a clinical definition that comes from the person who's menstruating, whether it has an effect on their physical, emotional, social, or material quality of life. And that's a far more useful clinical definition of what heavy is. So what is long COVID? I think Louise has given a lovely introduction and made this slide much easier for me to explain, but SARS-CoV-2 enters the cell via the ACE2 receptor with the assistance of the TMPRSS2 protease. And these 2 components allow the virus to enter the host cell and mediate its effects. So the NICE guidelines, National Institute of Clinical Excellence, have come up with these definitions, which I think are quite a useful starting point for acute COVID infection being from symptom onset up until 4 weeks. And then between 4 weeks and 12 weeks, if symptoms are persistent, then it's ongoing symptomatic COVID-19. And over 12 weeks, they describe it as post-COVID-19 syndrome. And what we are sort of terming long COVID, I think, encompasses both ongoing symptomatic and post-COVID-19 syndrome. So anyone who is experiencing symptoms for greater than 4 weeks, we would term them as having long COVID. So I think to give you an idea of some of the numbers, the Office of National Statistics in the UK have said that 1.1 million people are living with long COVID in the UK. And to allow you to perhaps extrapolate that to your own setting, about 14% of people who've tested positive for COVID, they're saying have symptoms lasting over 12 weeks. So that's a significant burden on healthcare systems across the globe. So I want to talk a little bit about long COVID and how it may interfere with menstruation and some of the problems that it could potentially cause. The data here are very scarce. So we just did a quick and dirty survey on a group of women who claim to have long COVID and are in a support group. So it's a relatively biased set of women. But they've said, we asked them the simple question, has your menstruation changed following the onset of COVID symptoms? And 83% of them said yes, they've experienced a change in their COVID symptoms. I think there's much work to be done here. Looking through the literature, there are perhaps 7 studies, 5 of them peer-reviewed, that have looked at menstruation during the pandemic or COVID. 4 of them are really looking at the pandemic and not specifically at COVID. 2 of them looked at the acute COVID infection, and 1 has asked some questions about menstruation in those with long COVID symptoms. But unfortunately, there's no analysis of whether they were on hormonal preparations or not. That study showed that I think about 36% of women had some change to their menstruation. And again, if women were on hormonal preparations, then clearly that would override their natural menstrual cycle and that may not present with the same kind of symptoms or effects. So really, we've no idea whether COVID or long COVID is affecting the duration, frequency, regularity, or volume. We've no idea what parameters are affected in women with long COVID. We don't really know the impact of hormone preparations because I don't think that's really been looked at fully as yet. And we don't know whether the symptoms that women are reporting are due to the effects of the pandemic, which clearly have huge implications in terms of stress and other effects, or whether it's due to long COVID or indeed even acute COVID infection. And I think we need to do a lot of work to try and tease out some of these mechanisms. And there is work ongoing at the moment. There's a group in Oxford and Montpellier who are addressing some of these issues in an online survey that was open to anyone who had ever menstruated, who was over 18 and living in the UK. And encouragingly, they've had 26,000 women provide responses to their very comprehensive online questionnaire. And about 23% of the women have had a COVID positive test or symptoms that were consistent with acute COVID infection. So I think analysing some of this data will perhaps tease out some of the, separate out some of the effects of COVID itself versus general effects of the pandemic. And I think this is really important work that's been done, and I'm very much looking forward to hearing the results that come out of that study. So how potentially could long COVID, if it does cause menstrual disturbance, what may be the mechanisms behind that? Well, I think we need to first look at what are the mechanisms behind and the diagnosis behind menstrual disturbance in general. And this has only relatively recently been done, again, endorsed by FIGO, and have come up with a set of parameters for structural abnormalities that can cause menstrual disturbance and non-structural abnormalities, going by PAM-COIN. So PAM, P-A-L-M, for the structural causes, and COIN for the non-structural causes. So structural causes include an endometrial polyp, which is an outpouching of the lining of the womb or the endometrium. That can cause very irregular bleeding usually. Adenomyosis is where there's cells that would be consistent with the endometrium being found within the myometrial layer of the uterus, and this usually presents with very heavy, very painful periods. Leiomyoma are fibroids, I'm sure you're all very familiar with, as an overgrowth of the myometrial layer of the womb causing menstrual disturbance in many cases, perhaps sometimes asymptomatic. And then malignancy of the reproductive tract can clearly present with abnormal bleeding. My feeling is it's very unlikely that COVID would have a direct impact on the structural causes, although I can't rule that out entirely. I think it's more likely that it will impact on the non-structural causes of menstrual disturbance. Things like coagulopathy, 10% of women with heavy menstrual bleeding have von Willebrand disease, ovulatory dysfunction at the extremes of reproductive life or extremes of weight can cause irregular or infrequent menstruation and heavy menstrual bleeding. It may be a more microscopic endometrial cause and how the lining of the womb is functioning during a period in terms of how much inflammation there is, how much hypoxia is, how the vasculature is working within the endometrium. Or it could be something that we're doing, giving them hormonal preparations or anticoagulants that are causing the menstrual disorders. And we do need to bear this in mind when we think of some of the treatments that we're starting to use for COVID. The steroid medications will certainly have an impact on endometrial function. And not otherwise classified are things like endometriosis and AV valve malformations that don't quite fit into the other categories. So thinking about long COVID and menstrual disturbance, well, I think this probably could be divided into the HPO-E axis, and the general stress of the pandemic or the general stress of contracting a serious illness can create hypo-hypog and downregulate the whole reproductive system, and certainly will then naturally affect menstruation. But equally, it could be at an ovarian level that the defect is taking place with a disruption in the ovarian hormones, oestradiol or progesterone, or it could be at the endometrial level that the abnormalities related to COVID are taking place. And certainly know that the ACE receptors, certainly in 2 preprint studies, they've shown that the ACE receptors are present in both the stromal and the epithelial cells of the endometrium, and do seem to be present during folliculogenesis. So it seems plausible, at least, that COVID could have a direct impact on the reproductive system to cause some changes either at the ovarian level to influence hormone production and create ovulatory dysfunction and subsequent menstrual disturbance, or indeed at the endometrial level where the huge influx of inflammatory cells to the endometrium could be massively altered in a woman if she's had COVID infection. The phenotype and number can be affected, which can then change their function within the endometrium. There could be a lack of vasoconstriction due to the endothelial cell dysfunction that Louise had alluded to. And we know that COVID causes altered coagulation responses, and that's been very much in the media recently. And that may have an impact within the endometrium, the result of menstrual disturbance. So to sort of look at some of these things, we've recently obtained a small amount of funding to develop the ERGO study. And what we're looking to do once we have all of the ethics and things in place is to ask women with a diagnosis of long COVID who are of reproductive age and who have relatively regular menstrual cycles to start with, try and piece out some of these things, to attend for serum samples and endometrial biopsies at 3 different phases of their menstrual cycle. And we can compare these serum samples and endometrial biopsies with archive tissue that's been collected for women when there was no risk of them having COVID infection. And looking at some of the ovarian hormone levels across the cycle, some of the inflammatory mediators, not only within the local endometrial environment, but also in the serum to see if there's systemic impact, some markers of hypoxia within the endometrium to see if they're altered with and without previous COVID infection, and some of the coagulation factors that we know are very important in terms of cessation of bleeding during menstruation. And I really hope that this will give us some preliminary data on what potential mechanisms may be involved that cause menstrual disturbance in these women, because it could be a very significant long-term problem for a number of women. And really the aim is to identify the specific cause so we can get a specific treatment for women. And I think if we can target the exact defect that women with long COVID have, then we can develop more precise treatments with fewer off-target effects. So for the last bit of the talk, I just want to go through how I think that the menstrual cycle may affect the longer term symptoms of COVID. And again, Louise has said that there's a number of overlaps in symptoms between hormonal type side effects or lack of hormones and some of the symptoms that women are describing with long COVID. And I don't think there's complete overlap in that by any means, but there may be aspects of long COVID symptoms that could be more attributable to the hormonal impact that women may be experiencing following acute infection. So again, just a quick screen, and I'm not claiming that these are very accurate figures by any means, but we asked women in our long COVID support group, do your long COVID symptoms change across your menstrual cycle? And a whopping 95% of them said yes, they do. Other studies have looked at this without such a high figure, and there tends to be a bit of correlation with the premenstrual and menstrual phase of the cycle showing a worsening in long COVID symptoms. But again, we haven't really got to the bottom of this. We don't 100% know what stage of the cycle the symptoms are getting worse or better, or which type of symptoms are actually affected by the menstrual cycle. And I think there's a huge amount of questions that are just ripe for asking and trying to work out exactly what's going on. So again, we're going to ask women with a diagnosis of long COVID if they would take part in an app-based study. This is collaboration again with the group team in Oxford and with Newson Health, to use the Balance app to collect not only their menstrual symptoms prospectively, but also their daily long COVID symptoms across 2 to 3 menstrual cycles. So those who are of reproductive age with relatively regular menstrual cycles, not taking hormones, are the people that we're really interested in to see how the natural menstrual cycle affects their long COVID symptoms, but also those taking hormonal preparations that give them regular bleeds, almost as a control group, that have sort of steady state hormones on board rather than the natural flux of the cycle. And I think that'll be a useful comparison long term. And we're asking them to report their long COVID symptoms in specific groups and rate the severity of them on a daily basis to give us some idea of whether there's any change across their natural menstrual cycle. Potential mechanisms. It's very difficult to say at this stage whether there even is an association, but if there is, I imagine it would be very likely to be driven by the ovarian hormones because they have such a huge impact systemically across the cycle. But as well as oestradiol and progesterone, I think we need to think about androgens, which can change across the cycle and certainly have this very significant role within the endometrium, and glucocorticoids. And you know, they certainly have a huge impact around the time of menstruation, to control blood loss and inflammation within the endometrium. And I think that can be a really interesting association to look at, particularly if we think about iatrogenic causes, menstrual disturbance and COVID. So really, the aim is to try and see if we can develop some kind of useful, effective, safe therapeutic strategy for people with long COVID. And to see if we can develop more specific treatments for women having menstrual disturbance and abnormal uterine bleeding. Really get effective treatments, specific treatments that really personalise how we're dealing with these symptoms, minimise side effects. And I think it's unlikely that one size will ever fit everyone. I think unless we start to collect the data surrounding menstruation and COVID, we're never going to move things forward. So I hope I've given you a bit of an overview about menstruation and COVID. I'm sure there are lots of questions about what those relationships are. There's certainly lots in my head, and I'm hoping with some of the work that we're starting to do, we'll be able to get some answers for people in the relatively near future. But as I say, unless we start looking into this, I don't think we're going to get any better in terms of our treatment of long COVID or of menstrual disorders. We have developed a website called Healthy Optimal Periods for Everyone to give some background for the lay public on menstrual cycle and menstrual disturbance. And I'd be very grateful to get any feedback on that. And if you think it's useful, it could be something that you might want to give out in your clinical practice to give people some information to empower them regarding their menstrual health. So lastly, I've just a slide to thank all of the collaborators who I work with. And really, I think the big shout goes to the research participants who are helping us with the research, and the funders who supply some of the money to make it possible. So thank you very much.
Thank you, Jack. Thank you for that, Jackie. So, not surprisingly, we are inundated in our Q&As, and what we'll try and do in the next 20 minutes, I think we're going to give ourselves 20 minutes, is run through as many of these as we possibly can, and probably best if I just go through some of them and we try and, I would say, give relatively short answers. Let's see if we can cover as many as possible. I think colleagues, Louise, Jackie, you also have access to the Q&As, but I was going to start with one of the questions that came in earlier about vaccination, And the question is, we hear from vaccinated females in perimenopause stating that immediately after being vaccinated, their period cease. Is there any scientific support or comment? Is that an observation that that you, perhaps Louise, have seen at all or seen reported?
Yeah, I mean, it's definitely heard a lot, not just in patients, but on social media as well. And I'm sure it does. I'm sure there is an effect. It's very interesting. We've got 14,000 patients in our clinic, and very few of them have had any reaction or side effects with the vaccine. And you know what I'm going to say, it's because they're all well estrogenized. And so it's very difficult to know, is it a coincidence? There will be women becoming menopausal, stopping their periods every day. There will be women becoming perimenopausal every day, and then they have a vaccine, and obviously, you know, does it cause it or not? But I think there's too many that have really noticed, and certainly we noticed that women who are perimenopausal and women who are menopausal not taking HRT definitely seem to have a worse deal of the vaccine. I don't know if Jackie wants to comment on that.
Yeah, well, I mean, I think my answer is going to be the same for a lot of these questions. We just need the data, and reassuringly, there is a team in America looking at this and collecting data on vaccination and menstrual disturbance. My gut reaction is that there probably isn't going to be a massive impact on fertility or anything worrying like that. I think we've seen these kind of menstrual disturbances with other vaccinations. I think there's a stress response. I think that can knock things off. Clearly, the reproductive system is exquisitely tuned to downregulate at times of stress. I think from the data that I've seen so far, I think I'm relatively reassured that it's very safe to get it, and it's not going to have a huge long-term impact on fertility or anything else. But I think there may be a little bit of, you know, I think we can't deny there's receptors for COVID in the reproductive system, and it may have a small effect somewhere. And I think until we've got the data, we can't say anything for certain. I think I would be relatively reassuring to people at present that it's very safe to get the vaccination. It's certainly safer than getting COVID. And it would be really interesting to see the results of these studies coming through on the impact on the menstrual cycle.
There's emerging evidence that that individuals with long COVID actually respond well to vaccination, and actually there's some evidence that vaccination can help folk with long COVID. And I just wonder again whether there's any, I mean, part of that I've always assumed is some sort of almost resetting of the immune system, but you do wonder how this is going to impact on the whole sort of hormonal environment and what that means for both pre and post menopause. Actually, it'd be quite interesting when we've got the data to look at that. Anyway, we just carry on. So there are several questions around dosage. It's a bit specific, but what dosage is considered? I guess we're talking about estradiol dosage for menopause as protective in terms of COVID, and how does that relate to what we know about doses that are protective for other diseases?
I think it's very difficult with doses. It's very hard to know, even with other established diseases such as cardiovascular disease, you know, dementia. All we try and do, or certainly in our clinical practice, is try and reach physiological levels, and the dose doesn't actually always equate. So we often have quite a pushback from other clinicians saying, well, you've given someone with POI, early menopause, too high a dose, but actually all we're doing is achieving physiological response. So, and I think that's the same with the immune system as well. Looking at some of the studies, it's very hard actually, because a lot of studies have been done. Some of them have been doing using estradiol levels on oral estrogen, and it's just, you can't equate the same with the 70 beta estradiol. So when you look at disease prevention with HRT, I've already said reducing these diseases. And it's very interesting when you look at the diseases such as diabetes, cardiovascular disease, even clinical depression, dementia, they are all pro-inflammatory, you know, these IMMs, these macrophages that are programmed wrong without the estrogen. So that's why it's also linking. So the more we can have estradiol at a high enough to suppress this inflammation properly and get our immune systems working, the immune system will help with COVID or other infections, or hopefully COVID, but certainly other infections, but also that's how it helps reduce these other diseases as well.
Okay. A question here about confounding factors. The question is, as women taking HRT tend to be healthier than women healthier than women not taking HRT, And we know that it has that effect, you know, with obesity and diabetes. Is this something one needs to take into consideration?
Absolutely, and it's this whole pushback always about HRT is that healthy people take HRT, and my narrative would be actually women are healthy because they take HRT. And certainly looking at the Oxford study, they match people for their weight, their socioeconomic, their health records as well. So as near as possible, they were matched. So there are plenty of healthy people who don't take HRT, but they have health risks. And so we have to get away this fact that people take HRT just because they want shiny hair and nice skin. It's actually more about how it works systemically in our body. And if you take it back to the physiology and pathology, it's all there. This is what I'm told today. 90% of it we've known for decades, but no one's looked at it because they're so scared of HRT, sadly.
What are your thoughts, Jackie? Because again, the study you're talking about in terms of long COVID, there's going to be, there's going to be so many factors. Not least, well, of course, long COVID is not one disease anyway. It's clearly a loads of different things going on there. But also, again, this whole issue of confounding risk factors.
Yeah. So you could go on and on with this. I think it's really difficult to narrow it down. And I think from a scientific perspective, you have to carry out your research trying to make it as scientifically sound as possible. And you can normalize for BMI, smoking, socioeconomic factors, and we can do that with the women coming through with long COVID. It is difficult because we don't know if women with menstrual disturbance have, for example, altered endothelial dysfunction systemically and perhaps increased risk of cardiovascular disease. We just don't know these things, so we have to just try and work out as many confounders as we can to make it as reliable as possible. And I think we have to try. If we don't try, we're not going to get anything. If we try, it might not be perfect, but at least we're one step further forward.
Yeah, I think a lot of my tuppence halfpenny, and actually I did do a PhD in reproductive endocrinology, by the way. That was a long, long time ago. I think one of the problems with all of this from a scientific perspective is that estradiol is just too complicated, and that what we've lost over the years, quite sadly, I'm not sure this is true across the world, and other colleagues on the call may wish to comment, is a proper approach to what I call integrative physiology. People, and I'm just as responsible for this as everybody else, but we've all been rather reductionist. We all work on a single gene, or we think we've got a targeted drug or something. And when you start looking at something like the menstrual cycle and the hormones, you're like, oh my goodness, it's really complicated.
Yeah.
And I think that's what you guys are very valiantly trying to tackle, something which is really complicated. Can we move on anyway? So there's a question here about progesterone in HRT, and does that provide, do you think, any additional protective effect in relation to COVID? Louise, I don't know if you want to talk about that.
Yeah, and it's possible, and there is a group in Canada that looked at that actually, but I think there is a bit of evidence. The thing about progesterone, obviously, it's harder to look at because a lot of women still take synthetic progestogens rather than progesterone, and that has a completely different metabolic effect. But there's definitely, it's just prioritizing really. There's a lot more evidence to support estradiol as an immune modulating agent than there is with progesterone. And obviously, a lot of women who've had a hysterectomy only take estrogen, and we've got really good studies that those women have a lower risk of all these inflammatory diseases such as cardiovascular disease and so forth. So I think because women's health is such a disaster for research and menopause is even worse, you've got to start at something. And I think even Jackie alluding to testosterone with long COVID, I think is absolutely pivotal. We see a lot of women now, or an increasing number with long COVID in our clinic. And I'm not a long COVID specialist, but I know these women are still perimenopausal or menopausal, so I will give them standard treatment. And often the estrogen can help a little bit, but we've been astounded actually with how testosterone can really improve their stamina and their cognition. And one lady told me yesterday that she had managed to get off her wheelchair for the first time in 6 months, and she could quite quickly feel the testosterone actually working, but it's taken 4 months, but she's had to increase the dose. But her initial baseline blood tests were very low. So it's very difficult. I am not saying that estrogen and testosterone will cure long COVID, but what I am saying is that I think there's a lot of women out there who would benefit from hormones anyway, especially probably testosterone, that might coincidentally improve some of their symptoms, reduce the referral to long COVID clinics. So the long COVID clinics can see those people with proper long COVID, if you see what I mean.
Yeah, I think there's just such a lot of evidence that the reproductive hormones in general are affecting the immune system. There's work has been done around endometriosis and peritoneal macrophages, and the phenotype is massively different between males and females for peritoneal macrophages, and with the implications of whether that predisposes to endometriosis and whether the macrophage function is changed by the hormonal fluxes across the cycle. There's a lot of preconditioning of macrophage function, so they're very dynamic. They can change depending on the environment they find themselves in. And if you've got these hormonal fluxes across the cycle, does that precondition them to be more effective, more pro-repair rather than pro-inflammatory? And I mean, there's definitely something in that. It's whether our treatments are going to be effective if we don't completely mimic the natural menstrual cycle. And I know this has been a huge issue in HRT treatments, trying to get preparations as natural as possible. I mean, physiology is really good in the female reproductive tract. And I think if we can align it to as close as possible to that, then that's always a safe approach. But, teasing out these mechanisms, I mean, we have so much work to do. It's just a brilliant field to be in for that. Because if we can work out what's happening in the physiology of the female reproductive tract, which usually works absolutely brilliantly, amazing lessons we can apply to pathologies right around the body. The opportunities are huge. So if there's funders out there who want to fund this kind of work, that would be amazing, because I think it's just so important to do it. And I think women's reproductive health is a great place to start.
Okay, there's an inevitable question or two on venous thromboembolism, but both the risk in terms of HRT treatment, how that's affected postmenopausal, specific question around the effect of estradiol on thrombotic complications of COVID. Could you please explain it again, as estrogens can be pro-thrombotic, and how estradiol could reduce such complications? This is an inevitable question, I guess.
Yeah, it's a really important question, actually, but we know that transdermal estradiol has a very different effect to oral estrogen. So when women have transdermal estrogen through the skin as a patch gel or spray, it goes straight into the bloodstream. So it bypasses the liver, which produces clotting factors. So good studies have shown that there's no clot risk with transdermal preparations. And in fact, the way it affects nitric oxide and the endothelial cells, it actually is probably anti-inflammatory, if you look at the studies, it's sort of 0.9 as opposed to 1. So there's actually probably protective and actually a slight anticoagulation effect. The problem is, as you know, that often if I open my gel or patch, inside it will tell me there's a risk of clot, and when I prescribe it, it will say risk of clot, but actually that's just grouping all estrogens together. I did a presentation for Thrombosis UK a couple of weeks ago with Professor Beverly Hunt, who's the queen of thrombosis in the UK, talking about the safety of transdermal estradiol with clot risk, especially in view of COVID, and she was in a complete agreement. So it's not just me as a menopause specialist, it's actually in conjunction with her as well. So transdermal estradiol is absolutely safe. Even people that have had clots in the past and have a clotting disorder such as antithrombin 3 or protein C deficiency can still take transdermal estradiol. And also, it's not just the estrogen, it's the progesterone. The natural body identical micronized progesterone doesn't have a clot risk, whereas, as I'm sure most of you know, the synthetic progestogens do have a clot risk as well. So it's not just the estrogen when you're worried about clot with HRT, it's so they should have transdermal estradiol with the micronized progesterone, and there's no risk of clot with either preparation.
Okay, thank you for that. In the interest of time, I'm going to move on to some, I'm obviously going to upset people because we have to skip some of the questions, but there is one here about the virus, and is there virus in tissues? And I guess we're talking about reproductive tissues of individuals with long COVID. Not sure there's any evidence for that, but Jackie, you may wish to comment on whether, is there any evidence at all for a direct virus infection? Any of these, or is it all indirect?
Yeah, I don't think we know yet. There's one paper has been published looking in fertility and sterility, I think, looking at reproductive tissues, and didn't find significant viral infection in the tissues. I think there's 2 preprints that haven't been peer reviewed showing that the receptors are present. I mean, when I looked at them, they looked pretty good quality, but you know, they haven't been through the peer review process. I think we just don't have the answers to those kind of questions yet. I think it's unlikely it has no impact, but what the mechanism is, we just don't know.
And just going back to we've touched on it, but it's certainly worth coming back to about the possible effect of implications for fertility in individuals with long COVID. Can we just go back over that again? What your thoughts are?
Yeah, I don't. Well, I mean, I think we need to do the work to see if there is a significant proportion of women, for example, with decreased ovarian function. I don't know if it's tipping women who were already running out of ovarian function into the menopause. I don't know the answer to that. You know, I think it's reassuring that, you know, people are still menstruating, and it's just that there's altered cycles. I think it's a very small proportion of people where they're becoming completely amenorrheic. And I guess that depends on the mechanism. I think it's likely that a significant proportion of those will have hypo-hypog, which is reversible if you take away that factor, and their whole axis will regenerate again. There will be no long-term impact on fertility. So I think I would have to be cautiously optimistic about long-term impacts on fertility. I think there may be short-term fits. But again, until we look and find out the mechanisms, it's very hard to be very certain about anything.
And what do you know about clinical trials in this context, in terms of clinical trials looking at long COVID in the context of perimenopausal women? Do you know anything about that?
I don't.
I've been in touch recently with Charlotte Summers, who's doing a lot of this work you may know, in Cambridge, looking at trial interventions in long COVID. In fact, I did mention Louise to her in a conversation I had last week. And I want, because they're looking at a very large cohort and starting to think about different interventions, it may well be worth a conversation about the menopausal context, really. Yeah,
it's certainly worth collecting some of the data through these large studies to try and work that out. I don't know of anybody who's specifically working on it in the menopause. I think we've struggled to find people doing large clinical trials specifically looking at the menopause.
There's a wonderful question here that we can all deliberate on for hours, which is why women are so prone to autoimmune disease. Clearly, long COVID has a feature. It's interesting, isn't it, that the upside is probably protection from the severe consequence of acute COVID. The downside is perhaps a more hyperreactive immune system. But I guess, I mean, Louise presented some of the evidence and some of the possible mechanisms associated with autoimmune disease. I'm not sure there's much more we can say about why women are so prone to autoimmune disease. Is that?
I think it's because, you know, it's that fine tuning, as Jackie alluded to. The macrophages, I think, are key. And in fact, a long time ago, 1992, I spent many weeks listening to lectures about macrophages by a very learned professor in Manchester. And I was thinking, this is as dull as dishwater. What am I doing? And now I wish I'd kept my notes, because he was very key about macrophages. If they're not switched on properly, they're pro-inflammatory, they'll cause disease, they'll cause cancer, they'll cause infections. And if they work well, they're your best friend. And this is, I think, what's happening here. And as Jackie very eloquently pointed out, the whole balance with our hormones is really key. And if you get the good hormones, you know, you're on a roll with your immune system and your health. If they're slightly out of kilter, and it's probably the balance even with estrogen and progesterone, we don't really know, then that's where you go wrong. And this is where immune systems, whereas men are just a bit more low maintenance, maybe. Don't have it quite so complicated.
It's interesting, the kind of main autoimmune condition that we would see would be sort of lichen sclerosis, and it's certainly massively increased in postmenopausal women. So, I mean, the hormones are definitely influencing the function of the immune system there somehow, and it's teasing out how to absolutely optimize it. That's a critical thing.
I guess we perhaps for I think the last question, because we haven't covered pregnancy at all. And there are a couple of questions around pregnancy, and one of them is, what can you tell us about pregnant women infected with severe COVID? Is there a hormonal explanation for what it seemed to be, you know, a high death rate? I'm not sure about that data personally, but anyway. But are there any other aspects of COVID and pregnancy that might be informative, dare I say, in the context of what we're discussing this afternoon?
Yeah, so I think a significant proportion of the serious cases are due to lack of vaccinations, probably in pregnant women. A lot of pregnant women haven't been vaccinated, so they're the ones that are filling the ITUs at the moment, because they're the ones perhaps getting the infection. It's incredibly hard to tease this out. I think there is originally it was that there's no increased risk for pregnant women. Now there may be a little bit of more serious infection. It's just so hard to tease this all out. Yeah, again, I'm going to be very irritating to a lot of people by saying I don't think we know yet.
I think one of the things, I certainly was doing some work right at the start with some researchers in Liverpool University, and when COVID was first announced, they were all ready to pack their bags and live in the maternity unit and look after pregnant women, thinking it was going to be like swine flu or other infections, and then they weren't seeing people. And that some of the conversations we had right at the start was, is estradiol important? With both respects, you know, I'm harping on about menopausal, perimenopausal women taking HRT. They're on about their pregnancy, and I'm sure it is. Jackie says we haven't got research, but there's enough data now to show that, you know, it isn't pregnant women, it isn't young women who are dying from COVID, it's not women on HRT. So we have to look at the evidence, really. We have to look at the data and then think, well, how are we going to go into it deeper to actually explore? And sadly, so many groups that I approach are just not interested because it's about menopausal women or women taking HRT, sadly.
So what about this? Why don't we have this very final question, which is an interesting one. Do you know if somebody has tried to treat COVID infection in males with estradiol? That's a good question.
Yeah, so certainly this was looked at in Stony Brook. They put a really good proposal together looking at giving people who were tested positive with COVID estradiol patches, men and women. And but that's what I was saying, the uptake wasn't there.
Yeah.
We've put together something that might start, but it's very hard to get these trials off the ground. But we know that estradiol is safe in men. It used to be given to prison inmates actually to calm their mood, and that was a lot higher doses of oral estrogen. You know, I'm sure most men, my husband included, if they were ill, they would have some estrogen gel or slap a patch. It's only for a few days, like just to attenuate that cytokine storm. None of us mind getting COVID. We just don't want to stop the country, the world working, and also we don't want to die from it. So we can cope with a viral illness. We get them all the time. So I think there's very few men that would say no to some estradiol for a short period of time, and it is so safe. That's the ironic thing about it. If I had a choice between using some estradiol gel or using an immune modulator, immunosuppressant, or a biologic agent, I would always go for a natural hormone.
Right, I think that's a really good place to end. So just want to thank Louise and Jackie for what was a really stimulating webinar. Thank you all for attending. We have loads of people attending, and apologies that we couldn't get through all the questions, but it does demonstrate the breadth and depth of interest in this really, really interesting and controversial area, actually. So thank you for that. It just remains for me to thank the IMS for organizing the webinar today, and also just to mention that the IMS World Congress will take place, hopefully face-to-face, in Lisbon next year. So please look on the website. You can see the website there, and please join the Congress in sunny Lisbon next year. Thank you for attending today.